faculty talks, optimizing cataract surgery, basics, training and safety. Is there anyone else who's there?
No, none of them from this list.
Okay. So the first talk, Dr. Ashul.
Arshul is not here.
The Galaxy era, redefining presbyopia correction with Rayner Ray 1. Dr. Harshul.
Arshul is here.
Thank you so much to AIS for giving me this wonderful opportunity. And I'll be speaking on a very recent advancement in IOL technology, which we have got now. That's the Ray-1 Galaxy Spiral IOL. We all know that for years we have been using diffractive presbyopia correcting IOL to give full range of vision to our patients. But the main problem with these diffractive kind of lenses is of dysphotopsia, that is glare and halo, and of course we lose contrast sensitivity. So these are two main problems in diffractive design, which has been taken care by the world's first spiral IOL that is introduced by Rayner, that's the Galaxy IOL, and it's focusing on full range of vision to our patients from distance to near with less halo. So we all know that we can't cheat with optics. Of course, if we are getting something, we tend to lose something. But with the spiral optics, the halos is minimized so much that literally almost 70-80% of patients don't report them, and even those patients who have, they have very mild halos which gets adapted over time. So this new Galaxy IOL delivers full range of vision with minimized dysphotopsia, which is just comparable to enhanced monofocal or monofocal plus lenses, which is achieved through this refractive optics which is there. And it's also available in toric powers, and we all know that the acryl hydrophilic acrylic material is time tested and over 12 million has been implanted. And now very soon it's going to come in hydrophobic platform also. And it's available in power range from 5 to 30 diopters with 0.5 diopter increment, and toric power is also, toric lenses are also available from +6 to +30 diopters. So let's see that how the optics are. So if you see the surface construction of this particular IOL, you can see that it's made of different component. This is the far. So central 1.1 millimeter of area is for distance. It's not changed, but the holy grail is in the 1.1 to 3.3 millimeter of the optic zone, and after that again it becomes normal lens. So because of this 1.1 to 3.2 millimeter zone, there are spiral optics which is there, and it is the first IOL which is designed with artificial intelligence, which creates a unique spiral pattern for optimal patient outcomes. And this spiral pattern, it allows, you can see here this the defocus curve. It allows continuous variance of power, which focuses light at every position along the defocus curve, and it results in precise control of optical power from far to the near, and it produces, the best part is there are no bumps. It produces a continuous and smoothly changing surface, and there is a smooth and continuous full range of vision which is available to patient. So have a look at the defocus curve of this IOL. So we can see that till minus 2.5 minus 2.8 centimeter, there is a continuous defocus curve which is more than 0.2 log MR, which is equivalent to 2032. And if we have a look at the defocus curve of, this is black is the defocus curve of Galaxy IOL, and this blue is for trifocal lenses. So you can see that this is the continuous, and especially from far to intermediate, and this curve is higher, and of course it's smoother than trifocal lenses. Again, this is the graph which compares binocular and monocular defocus curve. Intraoperative, when we see, you can see this is a trifocal lens. We can see all these diffractive rings which are there in trifocal lens. Whereas in this lens, if you tell patient to look into light, you will hardly see some undulations there, the spiral optics which is there. So there is a very smooth surface. And this is the vision simulator which study was done, comparing halos and glare. On this left side is with the spiral galaxy IOL. On the right side is with the panoptics IOL. You can see the size and intensity of halo is very less as compared to the panoptics trifocal IOL. So this is the video which shows the implantation. It comes in the preloaded injector system. So you just have to put, okay. So there's a hole there, just like other preloaded lenses. So you just put some OVD or BSS there, close this cartridge, and this is the hydroimplantation technique. Just put irrigation cannula there, and it goes through 2.2 millimeter incision. See there, you can't see any rings there. The surface is so smooth. So in the end, after, if you tell patient to look in light, you'll see some spiral things which are there. See, when I tell patient to look on different sides, you will see some reflexes which are there. So coming to the patient selection and counseling, it's going to be same as for any trifocal patients, but we need to tell them that they may see some halo, but they'll go away with time. There'll be very little dysphotopsia, I think. So in the paucity of time, I think I'll come to conclusion that so this is the world's first spiral IOL which is designed with AI to deliver full range of vision with minimized dysphotopsia. And as you saw, intraoperative image suggests smooth optic surface without step, discontinuities, or discrete annular rings. It gives excellent binocular vision at all distances. And we saw clinical binocular defocus curve which showed full range of vision extension with smooth plateau between plus 0.5 to minus 2.5 of defocus. There is reduced halo and glare in the vision simulator tests for Galaxy compared to diffractive trifocal lenses. It's also available in toric powers. Thank you very much. Yes, Dr. Allen.
How is this spiral different from the other readoff lenses, technology-wise?
So it's a patented technology, as I said, that the same technique of spiral technology is also used in contact lenses also to give, So this gives smooth vision from distance to near as compared to rings, which gives 3 focal point, like, in trifocal we have 3 focal point, but there is a bump dip down in between. But because of this spiral technology, there is a continuous range of vision and there is no dip. So patient have a very good vision. And because of the smooth surface, halos and glares, they are also very less dysphotopsia. We can't get away with dysphotopsias at all, but they are less as compared to the
Trifocal.
Yeah.
Thank you.
Differs from synergy. They also say continuous vision.
Yeah, it
Synergy
gives, but dysphotopsia is a problem, sir. Now more and more we are moving towards the optics, which gives us less dysphotopsias. They give excellent near vision, intermediate vision, and this. But if you see the continuous range, you see this defocus curve tells us how a lens is performing. So defocus curve tells us everything. So good vision at near, intermediate is fine. But if we talk of continuous range, so slowly and slowly we all lenses, optics, they are improving to a point where we can, simulate a natural, what young people have, that kind of vision. Yeah, it's a combination of read off and, yeah. Yes. Near.
But with the advantages of clarity and contrast sensitivity like an add-on. So it has, best of both worlds kind of.
That is diffractive.
So only thing I'll tell everyone is to be careful of the A constant. It's light quite different. So you need to be very careful. In one patient I had minus 0.75. So A constant, you need to stick to what the manufacturer says. Yeah.
Good morning, sir.
Yeah,
Nice
hi.
talk, Dr. Harshul. Sir, dysphotopsias not only depend on the rings, but also on the refractive index of the lens. So, and negative dysphotopsia will happen with any lens because it is properly implanted in the bag. Basically, that negative dysphotopsias we can't reduce. It's basically positive dysphotopsias like glare,
Yeah,
halos, and
of course.
starburst.
Of course.
But they also depend. So, what is the refractive index of this lens, sir?
Refractive index, I'm not sure.
Because
I don't
mostly
remember
it
the
is,
refractive
if it is
index.
hydrophobic oil, then acrylic hydrophobic oils have the maximum number of dysphotopsias, then silicone oils, then last acrylic hydrophilic oils,
Yeah.
because of the reduced refractive index in hydrophilic oils. Yes.
Yeah.
Yes, ma'am. Yes, ma'am. In some studies, ma'am, in some studies, it has been said that we place it temporarily, the optic-haptic junction, that tends to reduce negative dysphotopsia. But
So mechanism
So
of
inferior
negative
temporal.
dysphotopsia is totally different. We are talking of positive
positive
dysphotopsia.
dysphotopsia,
Yeah.
basically.
Yes.
Exactly. Thank you, sir.
Lack of time, we'll move on to the next speaker, Dr. Anaga. The secure choice for astigmatism correction, Dr. Anaga. Thank you, Dr. Harshul.
Very good morning to one and all. Thank you so much. So, no financial interest in any of the products mentioned. So, when we plan to do a toric IOL, what do we look at? First is complete astigmatic correction. So, you should have a good stability of the lens rotational wise. You need a good optical clarity, which gives you good contrast sensitivity. You should have a good ease of implantation because you're going to plan it in different kinds of settings. It should be a perfect platform with years of trusted technology. And post-operatively, it should continue to give optical clarity and reduced chances of PCO. So let's look at a few cases. So this is an intumescent cataract with a very high chance of a radial extension of the CCC. I'm planning to do a spiral CCC, and we are doing a premium toric IOL for this patient. So whenever you plan a toric IOL, in such cases, you need to have a very, very easy and good implantation of the lens. So here we are putting in viscoelastic into the infusion port, and once the IOL is put, we remember to remove the OVD from behind the lens, because if the OVD remains, that is a very high chance of rotation of the lens, and then you align it along the axis which is desired. I'm using the Varion system here, which is the markerless system. Now, a second case, a very high myopia patient who has already been operated for an IPCL many years ago, comes back with a cataract. So you have a double challenge. Now, this is a 2.8 millimeter incision. This is a care group IPCL. So with a hand over hand technique, I am removing the IPCL first. And then you can see the anterior subcapsular cataract there. A capsulotomy has been done. And we are putting in the IOL. It's a very high myope lens, longer axial length, remember, so you need to have a good rotational stability for this lens, again aligning it onto the desired axis. Third case, again a challenging case with a smaller size pupil. I'm using a B-hex ring, but look at the ease with which the IOL goes into the capsular bag in spite of the B-hex being there. and can be easily rotated and implanted, and the B hex is removed. So what is common in all these cases? The commonality here is the lens, which gives us the astigmatic correction to its complete extent and a good rotational stability. So let's evaluate it. First thing is you need to have a perfect biometry. See that you have a good optical surface, ocular surface, you get perfect K readings, use the PCA, the posterior corneal astigmatism has to be considered, and you need to have special features on the lens, like you have textured rough haptic surface. This is the Hoya lens, which has the toricity on the posterior surface and an asphericity on the anterior surface, and you get from T2 to T9. The important thing is you have a multi-cert preloaded technology, so you can see here the injector knob as well as the plunger. So if you are using a single-handed technique, you can use or a bind-handed technique, and goes in very easily through a 2.2 millimeter incision. So if you look at the rotational stability, these were 103 eyes which were evaluated at 1 hour, 1 week, 1 month, and 6 months, and you can see a rotation of just 1.1 degrees at the end of 6 months. We have a lot of options available today, so when you compared it with the other lenses, you found that none of these lenses rotated more than 5 degrees. And in a longer axial length eyes where you feel that there could be probable rotation, 100% of these eyes had less than 10-degree rotation. And again, comparison with other lenses for the decentration as well as for the tilt, you can see that the decentration is absolutely negligible. These are our first 100 eyes that we had evaluated, and the post-op residual astigmatism, 98% were within 5 degrees at 6 months. Why do they not rotate? Okay, one is because of the textured rough haptics. So they grip onto the capsular surface at the edge of the capsular bag. Also, they avoid optic sticking when it is folded. And the optic edge is also textured, so it reduces dysphotopsia in these patients. As regards clarity of vision, there is least PCO rates because of the ozone surface modification. So how does this happen is they are treated on the surface with UV ozone. This causes greater adhesion of the lens to the capsule and to the surface, and this increases the sticking of the IOL to the surface, reduced PCO rates also. Few additional features, just in case there is a slight amount of decentration, the amount of coma that is induced is negligible because of the off-axis alignment, and no glistenings compared to the other lenses that are available. So you continue to have greater clarity. Plus you have benefits of a good preloaded injection system. So if you noticed in all those lenses there, it gives you very quick implantation as well as eliminates the need for post-operative cleaning, sterilization. There is no chance of mishandling or misloading of the IOL, and saves time in the operating room. So basically greater efficiency, predictability, as well as safety. Most importantly, I've been using this Vivinex platform for the last so many years, not just for the torics, but even for the other monofocal lenses. So whether it's a 10 diopter lens or a 30 diopter lens, if you compare the amount of resistance force that is used to deliver the lens in the push mode, no matter what the diopter, it goes in with equal ease. So in all, all you need for best toric outcomes is a perfect biometry, a meticulous surgery, good rotational stability of the lens, and for good clarity, you need a good material as well as a good preloaded injector system that helps to give the greater ease of implantation. So thank you so much. All in all, to get better visual outcomes, a very humble request for your support. I'd be standing for member scientific committee in the ensuing AILS elections. Thank you so much for your kind attention.
Thank you, Dr. Anaga. Any questions for Dr. Anaga?
Definitely more thick, but sir, if you compare this, the amount of resistance that you would need to go is as good as a 10 diopter lens. You will never know the difference, and it goes in through a 2.2. If you have used above plus 30 plus lenses earlier, you would have realized that you need a MDCL cartridge, and the amount of pressure is also more. So that is a very important difference.
In your HMSC case, that capsule was very nicely stained. Do you use any different technique to use the anterior capsule?
No, sir. I make it a point to keep it for 1 minute.
1 minute.
Yeah.
Same dye?
Same dye.
Okay.
Same dye.
Thank you.
Thank you so much.
Thank you, Dr. Anaga. Next, I call upon Dr. Deepthi Prabhakar Iyer for biometry using contact method. Is there a role still? Go ahead.
Good afternoon. I'll be speaking on the old is gold method, that is the contact biometry. Is there a role still? Yes, I would say there is a role still. What is a biometry? It is just applying your math to the biology. Nowadays, a cataract surgery is no longer a cataract surgery. It's a refractive surgery too. So all the patients who come to us will demand unaided 6x6 or N6 vision. So the most common cause of the dissatisfaction in these patients is because of residual refractive error, which is remnant after your cataract surgery. So the key is having a precise IOL power calculation would make the patient happy and would not give any residual refractive error. So now the question comes, which biometry to use? So we have a lot of biometry devices in the market. From the ultrasound biometry to the optical biometry, the immersion, the contact or the applanation, and a various number of optical biometry which uses different principles like PCA, swept source, and SDOCT, and OLCRA, so many principles. So basic requirement for any IOL power calculation is your axial length power, the corneal central axial length, central corneal power, and the anterior chamber depth, which can be easily given by a contact biometry also. The rest of the things are the accessories, like your lens thickness, the effective lens position, the white to white, or your corneal thickness. So this is a chart which is taken from the JCRS journal, which gives us the input of prediction of errors according to different parameters used. The effective lens position contributes to the maximum, which is basically a post-surgical outcome. The other two, the axial length or the keratometry measurements, can be acquired by our contact biometry too. So this is another chart which reflects the post-operative IOL errors, which contributes the most. Like the difference, like 1 mm difference in the corneal radius and the axial length contributes the most to it. And this is what is very important when we do any biometry, to take care we get the proper axial length and corneal radius without getting any corneal compression. So these are few studies which say like this is the contact versus immersion biometry study where there is no significant difference in the axial length measured by either of them, either using either of the devices or the techniques, and also ocular ultrasonic using contact A method with optical biometry. Here also the significant difference in the axial length was very less. So we have our own in-house study which is yet to be published of 300 patients operated by 2 surgeons of 5 years of experience in the 6 months, and almost 90% of the cases we had post-operative refractive error of spherical equivalent less than 1 diopter. So you can just have a scan printout if a surgeon himself is not doing, which shows all the parameters like the SD and the scans, all the correct amplitude scans and all, so that there'll be no chances of error or any compression. So the next thing is, there is another survey which was done in in UK, which was the common source of mistake which contributed to the A-scan biometry, and 90% was the human error, and 10% was the machine or the technical error. So the human error could be wrong A constant selected, wrong formula used, wrong K readings entered by hand, or wrong eye biometry. So I would just go through few cases for which I used the contact biometry in spite of having the optical biometry, which gave me a similar good results. So this is a case of mature cataract, and I tried to do a optical biometry. We did not get any scan there. And then with the contact biometry, I went ahead implanting the chosen IOL power. The post-operative refraction at 4 weeks was -0.5 at 90 degrees, which was an acceptable thing. Second thing, the patient had a kyphosis where I could not make the patient lie down. So again, using immersion was a little difficult in this case. So I had to go ahead with the contact thing. In case of very thick PSC, here also I did get a optical biometry reading, but it was very erroneous. Like it showed around 28 and 30, which was not acceptable. And I went ahead with the old is gold method. and then implanted the IOL, which gave me a very reasonable post-operative error. So I would just go through few tips and tricks to get the accurate A-scan reading. First thing is the position of the patient. Always, you can make the patient sit straight or lie down supine without any pillow support below. And fixation of the patient is very important. Keep the other hand or other finger of the patient fixating, or the light coming from the A-scan probe as a fixating modality. Always hold the fixation probe from the wire and not the probe itself. Second thing is you just apply a small drop of any topical anesthetic. Do not flood it with any antibiotic drops or CMC, whichever you're using. Just a very small layer of a fluid of antibiotic would be enough. Very important thing is to get the 5 amplitudes, the 100% amplitudes of the 5 amplitudes. The first one will be the combined anterior and posterior surface of the cornea. Then you will have the lens amplitude. And then you need to have your retina spike, which takes a sharp 90-degree bend, and followed by it, you should have a discrete scleral spike. So there should be a gap between your retina and scleral spike, and then the falling of your orbital tissue. So those amplitudes are very important. It's always, I would always say, better surgeon does it, whoever is operating to do it. If not, get a scan like this, which is shown there, so that at least you can know the technician has got the proper amplitude scan. Use appropriate mode, and also very important is when in IOL, certain IOLs, you will have different optical A constant for optical and ultrasound. So use it appropriately when you're interchanging, like when you take optical for K readings and axial length, you use your ultrasound. Use it appropriately so that you don't get an surprise, a refractive surprise. Gain, always don't do trial and error method. The picture on the right side, gain is high. Decrease it till you get a discrete amplitude. Like you have to see discrete retina and scleral spike, and then the appropriate gain is chosen. Again, always center of fixation, foveal fixation is very important. Misalignment would lead to absence of spikes. Corneal compression, they do not average it. Take different, see the scans individually and then choose it. So in special cases where there is posterior staphyloma, always do a B scan to confirm the relationship of staphyloma to macula. And in case of vitreous hemorrhage or asteroid hyalosis, there might be additional spikes. Do not get confused to it. So to conclude, I would say there is still role of contact A-scan biometry if all the above mentioned points are kept in mind. And in a tier 2 city practice with high volume cataract surgery, it's of great help. Provided a trained person does it, a surgeon himself chooses the amplitudes and scan. I would always say old is gold. Even though you have an optical biometry, always don't throw away your A-scan biometry. So my mentor used to say, using a surgeon who spends more time in biometry calculation rather than the surgery would have a very happy patient. So thank you.
While measuring with contact scan, whether 0.25 millimeter should be added in all cases?
Sir, sorry.
Compensate for the compression with the probe.
Yeah.
Some recommend 0.25 millimeter length should be added to.
No, sir, we don't use that, thing.
In a two-tier city, you do not need optical biometer. We can, even then we can have this only A-scan with the conventional method of immersion method. Yes. So, immersion method is not a costly affair. Even we were doing for last so many years the immersion method, and we compare with the IAR Master 700 with all the biometer. There was no difference in immersion method and the biometry reading. So in two-tier city also we can do the biometry with the immersion method.
But
contact method is the person difficulty is that one person you have to train lot. That's the sir said ki compression, what factor you are going to do for the compression.
There will be no corneal compression.
And there are in the city.
Same day you cannot do it. Main thing is.
There will be no corneal compression with the immersion method. Yes. Because without immersion, it measures less.
Sir, can I answer that question? If you use a Barrett, online Barrett, if that is the question, actually there nowadays you need not have to use this 0.2. You can just select whether you have taken it by a ultrasound or by an optical biometer. Automatically that uses.
But ultrasound with immersion method or without immersion, that is not in the Barrett formula, na? They ask only whether ultrasound or
Yes, sir. That is meant for immersion method.
immersion. But many doctors, they don't use immersion, just contact is easy. I think then we can add 0.25 millimeter to the axial length.
Thank you.
Now the next speaker is management of dry eye in cataract surgery, Dr. Elankumanar Pasupathy.
Thank you, sir. Sorry for this thing. I have another session in the other hall. From biometry, we are going into something which we used to feel even more light or even more less. When I was a resident or in the early part of the practice, we didn't even know about this concept of dry eye developing after cataract surgery. But of late, this is the main complaint that we face from the patients. What is this? Usually, it starts on the very first day of doing the surgery, increases till the 7th day, and then continues for around 4 to 6 weeks and automatically reduces. This is the normal course of any of mild dry eyes in case of cataract surgeries. However, why is it so very important? Look at these two studies, which were released around 2017, 2015, something like that. 75 to 85% of the population presenting for cataract surgery did not know that they had dry eyes. These are the patients who are going to say, your surgery created this problem. So then that was very important, and a surgical society, ASCRS, started giving a nomogram for a medical problem. It had to go down to that level. And how should a nomogram be? It should be consensus. Everyone should have a consensus. Could be easily incorporated into practice, reduce the chair time, and then of course, for all this to happen, it should classify whether it's visually significant or not. Now, what was dry eye causing? Not only IOL problems, usually with the axis, sometimes with the power also, but even after putting in a very good IOL, very good surgery, it used to cause a vision problem, and sometimes like this, infections which are happening because of dry eye. Hence, this particular talk is divided under these headings: pre-operative, per-operative, post-operative, and what is my preferred choice of drugs. Let's go to the algorithm which ASCRS had proposed. This is the algorithm. Non-invasive, can be repeated if need be, but most importantly, it is an idiot-proof, meaning your receptionist or even your optometrist can do this and still you can save a lot of time instead of getting around investigating. The first thing that has to be done is, of course, measure the IOL parameters, that is biometry. Why? Particularly if you are doing a non-contact, that is optical biometry. Why? Because once you touch the cornea, you cannot use an optical biometer. At least for how long? 2 hours at least. So if you do an applanation, put some drops, do not do optical biometry immediately. Next question is, give these people, okay, when you're doing that optical biometry, you can look at the Myers and decide whether this person has dry eye. With just that itself, you can decide that. Next question. Next, give him a questionnaire when he's sitting outside, ask him to fill it. They propose speed 2 questionnaire. Speed modified at that time called speed 2. But what I use is an OSDI questionnaire. Any questionnaire what you have can be given to the patient. He will fill it up and then he will come into your office. The next step, what they said, is practically impossible in India. What is this? They have asked us to measure osmolarity and MMP9, inflammatory mediators. What I do instead, this is practically not possible by a clinician, only big institutes can do it. What I do instead, all of us know that the normal tear film height is around 0.15 to 0.25. So anything lesser, anything more, definitely consider as a dry eye. Look at the meibomian glands. Even if you don't have a meibographer, you can just use a simple autorefractor or any other machine and see the quality of the meibomian gland. After this, the most important, LLPP, look, lift, pull, push. Look for any meibominitis, blepharitis or something like that. Lift the lid to see if there is anything behind. Push the lid so that the meibomian glands, how is that expression? Pull the lid to look at the laxity. Along with that, look at this pooling, look at the staining. This is the next step. Now from here, we classify whether there is dry eye or not. If there is no dry eye, go ahead with the surgery. If there is dry eye, further etiology aspect, neuropathic, neurotrophic, and most importantly, visually significant or not. How do we decide this visually significant or not? Lot of things, but this is what I look at it. When you're taking these Myers, if there's any change, that's number 1. Number 2 is staining. Number 3, very importantly, changing of the keratometric value with every blink. If this is happening, you're not able to get a good keratometric value, then definitely this is a case of dry eye. Visually significant dry eye. Visually significant, wait. Non-visually significant, go ahead with the surgery. Now, if you have to wait for a visually significant dry eye, how long do you wait? Minimum 4 to 6 weeks. Treat this patient. After 4 to 6 weeks, take up this patient for surgery. Do not rush with the surgery. You will have all these equipments, but then I would like to you go for a multimodal use, that is a tear check, which is used in the clinical side. That's what I have. Peroperatively, what do we do? That's a new technology, surgically temporal ocular discomfort syndrome. That's a new technology that's used because of the transaction of the nerves. It can happen. And how do you prevent this? Well, it could be because of the incisional damage. So reduce the size of the incision. Most important, more important than that, repeated irrigation and drying. Avoid this. So how do you avoid it? Use a viscoelastic on the cornea. Do not keep irrigating it. Reduce the eye drops. What I do? 2 times Paracan eye drops, 2 times povidone eye drops, and 3 times dilating eye drops. That's all. Not more eye drops are used. Reduce the surgical time. Reduce the surgical trauma. Look at it. Flax causes more dry eye than a regular phacoemulsification. Of course, reduce the incisional thing. This is per-operatively what you do. Post-operatively, I'll just skip this video because of the lack of time. I think I'm in the last 2 minutes. Post-operative regimen. Now comes the question. What is the things to be used? Question number 1, should we use lubricating drops for all these patients? This is a study that said group D, where a lubricating drop carboxymethyl cellulose was used, did better in all parameters. So take home message, use lubricating drops for all the patients undergoing cataract surgery in your post-operative. Second, using cyclosporine. I'll just minimize what I'm going to tell here. When should you use cyclosporine? Stage 2 dry eye onwards only use cyclosporine. That is what this study said. Third, all of us who have used dexamethasone before and now we are using prednisolone acetate, we know this. Which is better? Again, this study said dexamethasone caused less dry eye. Fourth, should we have to use an NSAID? Answer, no and yes. Meaning, no for most of the patient, only when required use it, and if possible use it only once a day. So what do I do it? I use these formulas to, of course, even dry eye things showed. But one important thing what I do, even if the patient is stage 2, I'll treat him as stage 1 when I'm doing cataract surgery. Stage 3, I'll treat him as, stage 2, I'll treat him as stage 3, stage 1. Meaning one step before is what I do. Last couple of slides, I'll rush through it. Which is the, even if you do not have all these fancy things, this is the Asia Pacific Dry Eye Society with just a fluorescein strip. You can diagnose what is the kind of dry eye and start treating this patient. So it doesn't mean that we should leave it. And here is my MGD if it is there. Stage the MGD, that's the classification. And what do I do? Stage 2, this is the cutoff for me. Again, I use a heat compress. Anything more than stage 2, I would like to use an IRPL, treat this patient, and then take up for surgery. Now, finally, what is the medicine to use? We know that dry eye disease is a syndrome, multifactorial. So again, multifactorial thing. But suddenly we'll talk of tear drops, lubricating drops. We use what is called as a multimodal acting drop. You can see here, it's only hyaluronic acid, which has multiple mode of action, at least 4 different types. Rest of them have lesser. Similarly, the next slide also proves the same. So my choice for a lubricating drop in case of dry eye in cataract surgery would be hyaluronic acid. Thank you for the opportunity.
Next presentation is a very important consideration for especially premium IOLs, because patient may get 6/6 vision but still not very happy.
Thank you, sir.
Thank you.
May I request the electronic people to just switch off those lights, please? Or we are moving down from the stage. And now I would request the next speaker, Dr. Saroj Gupta. She'll be speaking on phacoemulsification, creating the perfect wound. Oh, bhai. चलिए यार, थोड़े जाते हैं, हम वहाँ आ जाते हैं। सुन नहीं रहा पीछे कोई, हम ही आगे आ रहे हैं। हाँ, थैंक यू। थैंक यू। सत्याग्रह के बिना काम नहीं होता है. Dr. Saroj Gupta, please.
Very good afternoon to all. I'll be talking on how to create a perfect wound in a phacoemulsification surgery. So you all know that creating a perfect incision is the most important step in cataract surgery, because all the steps which you are going to do later on depend on the perfect incision. It also influences the fluidics of the anterior chamber, and therefore a properly constructed wound ensures a self-sealing watertight wound, whereas a poorly constructed wound will make the surgical stress more difficult, and there's an increase in risk of complications if your wound is not perfect in phacoemulsification. So there are certain prerequisites for perfect incision. One is it should be secure, it should be self-sealing, it should be astigmatically neutral, and should be appropriately sized. It should not be too tight and not too wide. So there are many types of incision which are practiced in phacoemulsification. The older one is a sclerocorneal incision. It could be clear corneal incision, which is made away from the limbal arcade, or could be limbal incision, which is made at the periphery of the cornea near the limbal arcade. So sclerocorneal incision is not very properly practiced these days. We are all doing now temporal clear corneal incision, but if you have to make, it should be square, lying within the astigmatic neutral funnel, so that there is no surgical induced astigmatism. External incision is about 1.5 to 1.5, and it is a square incision, and the size depends on the size of your phaco tip, 2.2, 2.6 or 2.8, depending on which you are using. The depth is around half thickness of the sclera. Now this is used in certain special situations also, like in post-RK eyes. We use this incision, especially where it depends on number of incisions. The cuts in the RK, if they are more than 16 number, there's a little gap between the two cuts. Therefore, we do depend on this sclerocorneal tunnel incision, because otherwise these cuts will give way, and it is difficult to manage then. So in this post-RK, still we are using this sclerocorneal incision. But if we have about 8 cuts, then still we have a sufficient gap between the two incisions, so we can go for corneal incision. So still we have to practice this sclerocorneal incision also. Then coming to the clear corneal incision, it's also preferred method, has shorter procedure time. It is made anterior to the limbal arcade. There's no congenital manipulation, no bleeding, easy to make, good for surgery under topical anesthesia, and can be used as a refractive tool also. If there's an astigmatism, we can use it in a steeper axis. But there are certain limitations for this clear corneal incision, that the healing is slow because it is away from the limbal arcade, and it is nearer the visual axis, so more astigmatism, poor stability, and high rate of reports where the clear corneal incision gave rise to high endophthalmitis compared to sclerocorneal or clear corneal incisions. Coming to third type, clear corneal or limbal incision, where it is made near the limbal arcade, so the healing is better and more rapid, less SIA, because the temporal clear corneal we are away from the visual axis, but if we cut the conjunctiva, we are away the limbus, then it can cause ballooning of the conjunctiva due to the fluid collecting into the solar space. That is the disadvantage of this incision. Otherwise, it is an ideal incision which we normally use the clear corneal limbal incision, given usually in the temporal clear corneal temporal incision, which is widely practiced. Coming to the construction of the corneal incision, how do we construct this incision? Now, once you decided the site and the type of incision, it could be temporal, superior or superior-temporal. As I said, we prefer temporal incision, away from the visual axis, less astigmatism, better accessibility, especially in sunken eyes where the brow will obstruct our maneuverability. Location depends on the previously astigmatism also. Like it is with the rule as steep axis, then we always go for a superior incision. But if it is against the rule, then we can go for temporal incision. So it will help in correcting some amount of astigmatism also. Coming to width of the incision, should always match the size of the incision, because size of the phaco probe and the side port should match the size of the eye tip, because if it is wider incision, then it will allow the too much of egress of the fluid. You can see the fluid coming out of, in this case, from the side of this your phaco probe. So this will cause a shallowing of the AC intraoperatively, and this shallow AC will lead to endothelial damage as well as increase the risk of PCR because of shallowing of the AC. So it's very important your size of the incision should match the size of the probe. Coming to dimensions of the incision, if it is too narrow incision, then inhibits the movement of the phaco probe during the surgery, and may also cause collapse of the sleeve, and may inhibit the flow of fluid around the phaco needle, and may result in a harder cataract. We use more phaco energy, can lead to wound burn and fish mouthing of the wound also. This we have to, it should be of adequate size. On opposite to this, if the tunnel is very short, doesn't seal very well, and it may be too leaky, and if it is a short length, then it can give rise to a iris prolapse also. Whereas the long tunnel will restrict the movement of the instrument. Therefore, it should be square of adequate length, so that iris doesn't come out, it seals very well. Coming to architecture of the incision, there are 3 types of incision, could be uniplanar, biplanar or a triplanar incision. We can make in one plane directly going obliquely into the cornea. We can make 2 planes, first vertical then going obliquely, or it can be triplanar incision. So in uniplanar incision, it is water tightness is very less because we are directly going through the blade into the oblique direction, single incision we are giving. So the wound stability is less compared to the biplanar and the triplanar incisions. If we make a biplanar incision, then it is more stable because first we are making a vertical single incision and can be made with keratome or with a BP blade, whatever is used to, and then we are making a oblique incision. So it's a valvular incision, so stability is better, less astigmatism. Then coming to the triplanar incision, which is very good for beginners especially who are practicing the clear corneal incision for the first time in the beginning. So here we are making the vertical incision first, followed by a oblique incision inside the cornea, and then we enter into the anterior chamber. Good stability, either we can use a single keratome blade to finish all the 3 stages, the vertical, the inside the cornea and the entry, or initially for the beginners like for PGs, we teach them to first make with the BP blade a vertical, then go with it, make a tunnel with the crescent and then enter with the keratome. It is a good stability, good valvular action and good stability, less astigmatism. Coming to side port incision, it is used to fit the, for the second instrument. Again, the size is very, very important here. It should fit the size of your second instrument we are going to use. If it is a large, again there will be leakage of the fluid from the AC and will lead to the shallowing of the AC. We make it near the limbal arcade for better healing, long-term stability, and it is about 60 to 90 degrees from main incision to facilitate the intraocular bimanual procedures. It is very important to use a good and a sharp blade in the side port incision also, because if your blade is blunt, not able to enter, or the tip is bent, then it is difficult to enter, the incision will be ragged and there are chances of descending membrane detachment. So you should always see that your blade is sharp and it is easy to enter into the side port entry. At the end, evaluate the incision very carefully at the end of the surgery. Hydrate the incision properly, check for water tightness, very important. And if you find that the incision was leaky, either main port or side port, and it was leaking, it is a large, so we always can apply the sutures to make it watertight. So take-home message, well-constructed incision is very, very important. First step, we determine all the future steps of a cataract surgery. So for a successful cataract surgery, it is very important to have a good constructed incision in the phaco surgery. Thank you.
Sometimes the incision is very good, but at the end of surgery, the wound is not watertight, and we think that some suture should be applied. There is one super incision.
Yes, yes. You can make a super incision to hydrate
keratome we have to make in the upper layers of cornea.
You can make the super incision, or you can make a very small side port incision, one more, and do the hydration. So you have not to touch main incision again and again. That will cause corneal edema. So super incision is a very common. I don't remember the name of the surgeon.
I think from Singapore.
Yeah, I don't remember the name. We are doing it. Otherwise, you make a very small side port incision on the other side, and you do the hydration that time. Main wound will not be disturbed again. Not corneal edema there.
But if the wound architecture is not proper, then that
side port will do the sufficient work. That small, very small side port again, one more, and do the hydration.
Okay.
So ma'am, in most of your incisions, in most of your videos, you first make a partial thickness incision and then you go in. So is there any specific advantage of using that partial thickness incision?
Triplanar incision is the best incision, which we give vertical first, then we enter in the corneal lamella and then enter the anterior chamber. That is for the beginners to make the tunnel properly using different blades.
Second advantage
of
this horizontal incision which she is giving is, there is no fluid collection under the conjunctiva. When you make first small incision horizontally, then conjunctiva is cut in that part, so there is no fluid collection in the conjunctiva. So that is another reason, good reason for giving this work for horizontal incision. Even not we are giving it at our.
Yes. Thank you.
The next speaker is Dr. Stanshu Mathur, cracking the rock, phacoemulsification in hard cataract. It is your turn.
Good afternoon. So we have done the wound construction. Now we come to the
difficult part in the phaco, that is hard cataract. Start kar do. So there are many techniques to handle the hard cataract. This is the cataract chop technique that cataract I saw in the Philippines when I was visiting there for in a conference. So there is a small hole in the center, and from there the whole of the lava comes out whenever there is a volcano. So cataract reduces the mass of the nucleus before fracturing, and then chop enables. Back karna ek minute. Yeah. Sculpt a shallow crater in the center of the nucleus by sculpting, leave outer rim intact. We make a small sculpture just like shown in the figure in the center. It is known as debulking technique. So then edge of the crater is held with phaco and with under high vacuum, no phaco power is, you see. The crater is made in the center, and then we are just using the phaco probe with a high vacuum at the margin of this crater and doing the chopping. So no energy is used. So only energy is used in making this 3/4 thickness center crater, and when we are chopping it, there is no energy, only the high vacuum is used to cut the hard nucleus in different pieces. So we are cutting the hard nucleus, but just chopping. Second instrument doing all the work. No power is used in chopping. Then emulsify small pieces in the space created by the crater. So this small pieces then bring in the center, and they are chopping, they are emulsified. So this is the creation of the crater. We are using phaco energy, that is no doubt, but it is used for the very less time, because we have to make a crater in the center only 3 millimeter, and that is not through and through, this is only the 2/3 thickness. So once this crater is formed, whatever energy is used, it is used only here. Next steps in the phaco, we will not use any energy, so the cornea endothelium is safe in the hardest cataract also. So once the crater is, we are creating, once the crater is formed, this whole, once the crater is formed, we hold the margin of the crater, and by the second instrument, chopper, we just cut it, and you'd see, we are not cutting it, we are doing lateral separation also. This is very important. Lateral separation done only in the periphery, we are not going in the center till now. So we are doing lateral separation, you see. So all the part is separated. Now, go in the other part, leave the piece here. We are going to the other part, just holding, just they see, hold at the margin, holding margin, vacuum is used, no power, and the cut and lateral separation. So all of the cataract, hard cataract, gate 5 cataract is cut. Just rotate, all the pieces are there. Reason is why we are leaving the pieces there, because they protect the endothelium. Now we are just taking it out. So energy is used only for the making the crater. Rest of the thing is done by the vacuum, and now we are emulsifying under the lower. So this technique permits in back phaco emulsification or large cataract without complications. This is the one technique. Then another technique we are using. This is the cave. In this we are going inside the nucleus, just like we are going in a cave. Our upper part is the nucleus, lower part is the nucleus, and we are going phaco probe in the center. So, cornea endothelium and posterior capsule both are safe. See. Routine things are same as we are doing in every surgery. I cut fast forward this. See, now phaco probe, it is sculpting. We go in the center, hold the nucleus by the second instrument, sculpt, very small part. This is sculpting of the modifier. Now we are going inside the nucleus. See, we are going inside the nucleus. Upper part is the nucleus, lower part is the nucleus, we are going inside. So no energy, whatever we are generating is not going to damage the endothelium. So, and when we have crossed center, then other part is pushing the nucleus down and chopping it. Because we are going inside. So hold is so good that you can do the chopping without using the chopper. You can do with the dialer also. Because hold is so good, one instrument holding, other just cut it and it will divide. We are going, and now we are cutting, chopping with the other instrument. We are pushing it down, nucleus, going inside the cave, and now it has. So you see all the nucleus is separated. So this is very good technique. Less phaco energy is used. Phaco energy, whatever you're using, it is inside the cave, so it is not going to cause damage to endothelium, which is our main concern in hard cataract. You can use this technique in all type of cataract except the very, very, very hard cataract. You see, again we are going inside. And once we reach there, just press the dialer, it will cut the nucleus because hold is so good. So this technique can be also be used. There are other techniques also, whatever you like you can use to tackle the hard cataract. Whenever you're cutting, do not do the superficial vacuum holding. You go deep inside and then cut. So in this way you can easily chop the hardest piece. And then it is very easy. Now I leave the pieces there only. We are not taking it out because they put at that postage capsule. Now once we have chopped or done all around, we are removing it by bringing the center one by one. Phaco energy total use in both the cases does not affect the endothelium, and you get the clear corneal average. Thank you.
Thank you, Dr. Mathur. Even we can do chopping without using ultrasound energy, only with the phaco probe and horizontal chopper. I have designed a chopper with the sawtooths in the vertical part. I can do the chopping without using phaco energy. In all the cases, hard cataract cases can be broken into multiple pieces.
But
The
then we
phaco
have
tip-
to use
phaco
very
tip-
sharp chopper, sir.
That is for horizontal
Yeah,
chopping.
yeah,
yes,
horizontal
sharp
chopping,
chopper.
yeah.
And phaco probe acts like a chopper also. It moves
Yeah.
from this side, that moves
Chop
on
either
this side.
side.
Horizontal chopping.
That's why the holding it should be good, only then you can do the chopping.
Yes. But the additional advantage is after horizontal chopping, the pieces become softened. So less energy is used. After vertical chopping, the strength of the hardness remains same. So that is, horizontal chopping is better for hard cataracts.
My question to Dr. Satanshu, how much is total phaco energy time you use in such a hard cataract?
That depends upon the case to case, but it is what I want to tell you. Normally what we had do hard cataract, in comparison to that, it is less energy used. Because that cave is, only cave is made. We are not doing through and through chopping, to two-third thickness, and only center energy. Whatever energy we use in the normal hard cataract, it is very less in comparison to that.
You don't use any sharp chopper even in hard case?
Not in the cave technique, but in this in the cataract chop technique, we have to use the chopper because we are using vacuum and we are cutting. But a cave technique, you don't need to use any sharp chopper. Only dialer will suffice. Because holding is so good.
Thank you, Dr. Satanshu. That was a wonderful talk. And now I'll invite the next speaker, Dr. Jatinder Singh Bhalla. He'll be speaking on intracameral antibiotics, fact or myth. Dr. Bhalla.
Yeah, thank you, sir. Thank you. At the outset, I'm thankful to AIOS for this opportunity. The topic I'm going to cover has the time come to start using intracameral antibiotics in all the cases? We all know that prevention is better than cure. The incidence of endophthalmitis that used to be 0.087% in the 90s suddenly jumped in the year between 2000 to 2003 to 0.26%. And this was despite advances in the medical technologies, and some of the causes were changes in the surgical technique, clear corneal incision, and the aging population. There are two mechanisms for intraocular bacterial contamination, even in uneven full cataract surgery: entry of multiple instruments and unsutured clear corneal incisions that are not properly structured may lead to influx of the fluid from the conjunctival fornix into the anterior chamber if there is hypotony and the wound is not properly structured. And this has been published in JCRS, where they found that trypan blue stained fluid was found in the anterior chamber 4 hours after the surgery in poorly constructed wounds. So what are the problem factors? Non-use of povidone iodine, use of lidocaine jelly, wound leak, increase intraoperative time, and they have found more chances with hydrophilic IOLs. We all practice chemoprophylaxis. Some use topical antibiotics 1 to 3 days preoperatively. Some use subconjunctival antibiotics. 5% povidone iodine is universal, and intracameral antibiotics are most common and most popular in Europe. Povidone iodine is only for ocular surface decontamination. But if you want ocular protection after the surgery, then you have to give intracameral antibiotics. So once we know that perioperative antibiotics have become common stay, the only controversy was what route to practice of giving antibiotics. See, this is pharmacodynamics. If you use perioperative antibiotic drops, it is not effective in reducing contamination of the anterior chamber. Subconjunctival injections have been abundant. Systemic antibiotic prophylaxis is only reserved for high-risk cases. Antibiotic supplementation of the infusion fluid, it again fails to decrease contamination of the anterior chamber. And what they found was, if you start topical antibiotics several days before the surgery, 3 to 4 days, you achieve maximum concentration of antibiotic in aqueous of 2 microgram per ml. And topical antibiotics, some practice giving every 15 minutes, 2 hours before the surgery, it is less than 2 microgram per ml. Even if you combine the two regimes, you are not able to achieve more than 2 microgram per ml. But how much you achieve after giving intracameral injection? Close to 1000 microgram per ml. Why this figure of 1000 microgram is per ml is there? I'll specify in the subsequent slides. There is evidence by retrospective trials also, because there is difficulty in performing large RCTs. So most of the studies have been done which have used retrospective trials and not RCTs. There is ESCRS multicentral trial which was done by late Peter Barry in more than 16,000 patients, where they found that the risk of endophthalmitis decreased by a figure of 4.92. Then there are Spanish group, Singapore study and Swedish study, where they found that it decreased from single decimal to double decimal, like from 0.59% to 0.04%. Similarly, in Swedish study, it decreased to 0.06%. So there is change in practice pattern across Europe and US. 2011 American Academy Cataract Preferred Practice Guidelines, 2011 ASCRS Guidelines, 2013 ESCRS Guidelines, and in 2020 there is Australia Surgical Antibiotic Advisory Group on antimicrobial resistance, which all strongly recommend use of intracameral antibiotics. Once we are convinced that intracameral antibiotic has to be used, now the second question is, which antibiotic should be used for this purpose? These are the various antibiotics that have been used: cefuroxime, vancomycin, and moxifloxacin. EVS study indicated that 94% of the culture-positive endophthalmitis cases involved gram-positive bacteria, and only 5.9% were gram-negative species. So these are the spectrum of cefuroxime and vancomycin, which is effective against mostly gram-positive organisms, whereas moxi is effective against both gram-positive and gram-negative organisms. But there are problems with intracameral cefuroxime. There is lack of approved intracameral formulation, so there is kitchen sink pharmacy approach leading to dilution errors and toxic anterior segment syndrome. Then there is complete lack of activity against enterococci and pseudomonas, and vancomycin is reserved for treatment of endophthalmitis. So it should not be used prophylactically, because this is one of the very good antibiotics that we have in our armamentarium once infection or endophthalmitis occurs. But there are some serious adverse effects of vancomycin in the form of hemorrhagic occlusive retinal vasculitis. 22 cases have been reported in the literature till now, which is a blinding condition. Moxifloxacin has excellent coverage against both gram-positive, gram-negative mycobacteria, and also against anaerobic bacteria. There are two main terms which are used. One is MIC, minimal inhibitory concentration, and second is mutant preventive concentration. And it is not only MIC which has to be achieved, 10 times that MIC is mutant preventive concentration. That is the concentration or amount of antibiotic that should be there in the body fluids, which prevents the development of mutant strain of that particular microorganism. So now will come why 1000 microgram is required. If you inject 0.1 cc of 0.5% moxifloxacin, the concentration that is achieved in the anterior chamber is close to 952 microgram per ml. The MIC of moxifloxacin is 3 microgram per ml. So 10 times that MIC is 30 micrograms per ml. But we have achieved 900. Why? Because we want to maintain this concentration of 30 microgram per ml close to 4 to 5 hours in the anterior chamber. That is the half-life of this antibiotic. Only then we'll be able to really protect our patients from having any, even if there has been contamination. So the half-life is close to 1 to 2 hours, and MPC is retained, MIC is retained for 5 hours, and MPC is retained for more than 3 hours after the surgery. So this is one method. This is Cesar Espiritu from Philippines, who advocated using small volume high concentration method, which is 0.1 cc of 0.5%. And second method is by Steve Arshinoff and Modaber, where they use 3 parts of moxifloxacin and 7 parts of BSS. And third is Matsura from Japan, who uses super high volume dilution. That is, he uses 10 times diluted moxifloxacin, which replaces whole of the volume of the anterior chamber, that is almost 2 cc. So what are the advantages with moxifloxacin? No adverse reaction, no TARS, no hemorrhagic occlusive vasculitis, improved spectrum of coverage, and main thing is, even if infection occurs after moxifloxacin, it is due to resistant staph, which is sensitive to the standard protocol of giving intravitreal vancomycin. Whereas if infection occurs after giving intracameral cefuroxime, it is due to destructive enterobacter, against which we have no treatment. So this is another study, which was a very famous study by Arvind Haripriya, Indian study published in, from India, published in Ophthalmology, where it was done in almost 6 lakh surgeries. And this was another study which was published by Dr. Haripriya Arvind with Dr. David Chang. This was done on almost 20 lakh cataract surgeries, where they found that the endophthalmitis rate decreased from 0.07 to 0.02% with the routine use of intracameral moxifloxacin. So although the EVA study indicates that endophthalmitis can be treated and cured, but the best treatment is not treatment. Best treatment is prophylaxis. And at present, the best prophylaxis is intracameral moxifloxacin. See, the number of cataract surgeries performed in US in 2022 was 5 million. In India, it was 7.5 million. And globally, it was 30 million. So this is the maximum performed surgery in the world. So we need to maximize the safety of this surgery 100% and not even 90 to 95%. And in North America, Europe, and Australia, there is difference between endophthalmitis causing organism compared to that in India and China. And so moxifloxacin has better coverage compared to cefuroxime, which is better treated in Europe and USA. So use of safe and effective intracameral antibiotics should permit us to stay one step ahead of the bacteria and enemies that threaten our patients' vision. And so new ideas can take forever before being accepted, but no problem can withstand the assault of sustained thinking. Time has come to shed your inhibition and start the use of intracameral moxifloxacin in 100% of your patients, because it is backed by peer-reviewed published literature. So if you do not want to see red on seeing yellow inside the eye, please start giving intracameral antibiotics in all your patients. Thank you, everyone, for your kind and patient hearing.
Thank you, Dr. Bhalla. That was a wonderful talk.
Same Vigamox drop or any preservative-free moxifloxacin?
No, I think now we have many preparations available. We have pre-filled syringes also, because that wastes time. You have to open the drawer, then somebody has to pour into it. There are many companies in India now which are manufacturing pre-filled syringes. You just open the pre-filled syringe and you inject 0.1 ml. It comes in 0.5 cc. You can change the cannula and you can use in 2, 3, 4 patients also.
Is preservative-free or?
It is preservative. Moxifloxacin is mostly self-preserved.
Is Dr. Aditya Kelkar here? No. So we move on to the next presentation by Dr. Neha Khurana. She'll be speaking on dropless technique for inflammation control after phacoemulsification, their experience. Dr. Neha.
So very good afternoon to the esteemed panelists and the audience. So today I come before you to present our experience with dropless cataract surgery. So at the outset, I would like to address the problem of topical medication after phacoemulsification, the study we did, the results of our study, and then coming on to our experience. So globally, cataract surgery is the most frequently performed surgical procedure in eye, that we all know. And repeated installation of drops from time to time for a period of 4 to 6 weeks poses a lot of difficulties for cost, for epithelial surface of the cornea. Sometimes there may be contamination by the bottle tip, and especially patients with arthritis, dementia have a problem in instilling the drops at a period of 1 to 2 hours. So according to a study, about 36% of the patients were not able to utilize the eye drops as directed by their doctors, and over 1/3 of the patients required assistance while instilling the drops. So intracameral antibiotics, as sir has already shed light upon, is a routine which most of us are doing. For steroids, however, we are not using any such technique. Various routes have been used, including subtenous injection, transzonular, intracanalicular inserts, intracameral, and intravitreal steroids. We need something which is safe, efficacious, ergonomic, long-acting. We do not have a long learning curve also for it. That is also one consideration. So we plan to do a randomized control study to compare the efficacy of subcons triamcinolone acetate and compared it with topical prednisolone for the control of inflammation. 50 patients were enrolled in both the groups. Inclusion criteria were very simple. It was age-related cataract. Exclusion criteria was known allergy to any content of the drug, posterior polar cataract, known cases of glaucoma, uveitis, CME, etc. So this was the flow chart. Preoperatively moxifloxacin and ketorolac was given in both the groups for 1 day. After randomization, at the time of surgery in the intervention group, we gave subcons triamcinolone acetate 20 mg in 0.5 ml after the surgery, and intracameral 0.1% moxifloxacin was given in both the groups. And in the control group, 1% topical prednisolone acetate was tapered over 6 weeks, and intracameral again we gave 0.1 moxifloxacin for this group also. In both the groups, moxi with ketorolac combination was given for 1 week. So we also had intention to treat this thing, rescue therapy. We had planned that in case there is uncontrolled inflammation in any patient, we'll go ahead with whatever the patient requires for control of inflammation. We did examination, like we measured the AC cells and flare, subcon hemorrhage, and on days 1, 7, 21 and 42. And on day 42, OCT macula was done for the measurement of central subfoveal thickness, because CME also we all know is a manifestation of inflammation. So coming to baseline parameters in all the groups, they were comparable in terms of age, sex, grade of cataract, CDR, BCVA was again comparable. IOP and effective phaco time was equal in both the groups. So this is the cells. As we can see in both the groups, the blue and the red group, one is control and one is test. So we can see comparable inflammation in all the both the groups on day 1. Then again on day 7, again we can see comparable inflammation. Day 21 and again day 42. Almost all the groups, they had comparable inflammation in on day 1. In the cells part, and this is the flare. Again, flare was comparable in both the groups on all the intervals. So here comes the interesting part. IOP, we were expecting that probably there would be increase in IOP towards the later end. However, IOP at all times in both the groups was within the normal range of 12 to 14.5. We also measured the pressure spikes. Pressure spikes, we saw that in group A, 4 patients showed pressure spikes of more than 20 mmHg, which was the test group. And in the control group, 3 patients were noted. So for these patients, we had given additional anti-glaucoma medications. All these pressure spikes were noted on day 1. They were started anti-glaucoma medications. By day 7, the pressures had normalized, so the anti-glaucoma medications were stopped in both the groups. Coming to subcon hemorrhage was one thing which was more in the test group. So it was significantly more in the subcon triamcinolone acetate. You can see in all these eyes, there is subcon triamcinolone mixed along with the hemorrhage. So in these, it was even cosmetically disfiguring. It persisted up to 3 to 4 months. These deposits, they persisted under the conjunctiva for 3 to 4 months. So in the initial part of the study, although we were giving randomly in one of the quadrants, in the nasal or in the temporal quadrant, usually we were giving. Later on, we started giving under the lid, in the superior or the inferior part of the conjunctiva, so that the deposits could be obscured by the lid and were not cosmetically disfiguring. Macular edema, again, both the groups were comparable. There was no difference in macular edema, and it was in the normal range in both the groups. Neither of the groups had any CME. So coming to literature review, few studies have been done. One of the group, they have used intravitreal route for steroid. They noted pseudoendophthalmitis and floaters, which is a known complication of this. Then the second group, Dielman and Erickson group, they used DEXA and betamethasone. Both of them we know are soluble steroids. So soluble steroids have a poor half-life, and thus they noted uncontrolled inflammation in their study. Then transzonular triamcinolone acetate has also been used. This group, they noted floaters in their patients. Also transzonular route of triamcinolone, probably all of us are not very comfortable giving transzonular at the time of surgery. Then Reddy et al., this is an Indian group, and they have done 400 patients. They did the RCT in 400 patients. They also saw similar results. There was no difference in inflammation in both the groups. Coming to the conclusion, pros and cons of both the groups of triamcinolone acetate, it is not dependent on the patient's ability to instill the drop. Cost effective, arthritic and dementia patients, it's a blessing. Better ocular surface, good control of post-op inflammation in most of the studies before ours also. No IOP spikes at least up to 6 weeks. And cons would be, yes, subcons, hemorrhage and cosmetic blemish, which we saw in our group also. We should avoid in diagnosed patients of glaucoma as we did. Also in selective patients of uveitis, probably it could prove as a blessing. So take home messages, again the same. That was what our study showed, that probably we could use in some patients, especially very old ones and who cannot, who do not have a support system to instill the drops. Thank you.
Of that,
what's that?
Average time for disappearance of this deposit?
So disappearance usually by 6 weeks. We saw by 6 weeks they were present, but by 3 months they had almost resolved. After 3 months we couldn't see the deposits.
There was need of adding lubricating drops.
Lubricating drops, yes sir, they had to be given, because cosmetic blemish was the main problem, especially for female patients. We saw that.
Conjunctiva is raised and that can also alter tear film.
Yes sir, yes. So under the lid, when we instilled this injection, then it was better.
So less drops, not a drop less.
So just probably one, yes sir, yes. Lubricants had to be given for these patients. Yes sir.
But the frequency is less, lubricating only 2-3 times.
Yes. Glaucoma we had excluded pre-op only, ma'am. No, ma'am. None. Just the first week, that's why they were seen in both the groups. The pressure spikes we saw in both the groups. Just the first week, probably that was after the surgery only. After the surgery, the NCT was raised in some patients. But by day 7 in both the groups, the pressures had settled.
Suppose the patient sometimes turn out to be steroid responder, and we have injected triamcinolone, because we can stop the drop, but we can't, we have injected. So in that cases.
Yes sir, that may be there. The problem of steroid responsiveness is always there. But somehow in our study we have not seen. And plus we have used very less dose, 20 mg only we have used, 20 mg steroid. And again it is in the anterior part. So at least in our study we didn't see. If we see the theoretical incidence of steroid responsiveness is almost 30% what they say. But even till 3 months we have not seen. Probably the dose is less, and that's why.
It can be removed also if required.
Yes, sir.
Deposit can be removed also if it is required.
Probably, sir, it can be removed, but again, it would be a very messy surgery. That would be.
Thank you. Any other speaker?
Dr. Praful Marana, I think he's not come, he's chairing another session.
Dr. Aditya Kelkar.
Dr. Aditya Kelkar is not, so we come to the end of the session. Thank you everybody for joining us here. And any speakers around, if you wish, we can have a group photograph. Dr. Palla, ਤੁਹਾਡੇ ਨਾਲ ਹੀ ਸਹੀ